Are we live?
Yes.
Yeah, hello. Okay. Hello, everybody. I'd just like to welcome you to the first part of this three-part webinar series looking at rapid-acting antidepressants, so from ketamine to psychedelics. My name is Fionn Dunphy Doherty. I'm a senior scientist with Transformation. We're a preclinical CRO. So we're hosting this in collaboration with the British Pharmacological Society. So I'd like to thank them as well for all their help in organising and hosting this. So the webinar today, as I mentioned, it is the first part of a three-part series, and it will focus on ketamine's role in all of this. So the format for the webinar is I will bring up some discussion points and topics and address it to our panelists, and hopefully we can get a nice conversation discussion going around that. There'll also be hopefully a Q&A section towards the end. So if you would like to submit any questions, please do, and we will get to them towards the end of the webinar. So that just brings me to introduce our three panelists today that we have. Firstly, we have Professor Emma Robinson from the University of Bristol. She's a neuropharmacologist. She has a lot of experience working with neuropsychiatric conditions. She has a keen interest in translatability and validity of preclinical models, also a huge amount of experience working with ketamine and similar compounds in neuropsychiatric conditions. Our second panelist is Professor Declan McLaughlin from Trinity College Dublin, and also from St. Patrick's Hospital in Dublin as well. Professor McLaughlin also a huge amount of experience in terms of working with ketamine, both clinically and pre-clinically, and is the lead on the Karma Depth trials here in Dublin, which, correct me if I'm wrong, is the first clinical trials of ketamine in the Republic of Ireland, examining ketamine as an adjunct therapy for depression. And finally, our third panelist is Dr. Sandor Kantor from Transformation. He's an electrophysiologist by training. He's the EEG lead at Transformation, and also comes to us with a huge amount of experience working with ketamine over the years. So I just want to welcome our three panelists and thank them for their time today for joining us. So I guess the first place that I'd like to start is to kind of, not to go back to the very start of all ketamine research, that's probably going back too far, but maybe we'll take it back to a couple of decades and to kind of this emergence of ketamine as this rapid-acting antidepressant. And then maybe I'd just like to ask each of the panelists maybe their own first impressions of this as a concept, and then maybe what brought them to working with ketamine and the kind of research experience each of them has with ketamine over the years. So maybe Professor Robinson, if you'd like to go first.
Yeah, sure. Thanks for the introduction and thanks for the opportunity to join this. Looking forward to an interesting discussion. So I came into the kind of research looking at ketamine mainly from our interest in the mechanisms of antidepressants. We'd done some work with conventional delayed onset antidepressants and seen an interesting profile in a new model that was looking at this idea around modulation of affective biases. So these kind of integration of the biological and the psychological. And the obvious thing was to see what would happen with ketamine. And of course, nothing happened initially in the first sort of version of the assay. And then we were able to look at it in a different way and found this really exciting finding where it can modulate these affective biases over a much different time frame. And so that kind of really opened up a whole area and avenue of research for us. So looking at not just about efficacy, but also the differences between how conventional antidepressants may be working and then the rapid acting. And I guess I'm not that surprised that ketamine has these really interesting properties. And the more we're doing research, the more we're looking at this kind of modulation of prefrontal function and how drugs like ketamine are able to act. I don't think I am that surprised by what we're seeing actually. And I think it's opened up a really exciting avenue.
Okay, thanks. And Professor McLaughlin, maybe would you like to go next?
Yeah, I suppose from the clinical trial point of view, I guess we first came aware of ketamine really about 15, 17 years ago with the first Zarate paper, which is like a small study that had these very dramatic results with just after a single dose of ketamine. And prior to that, there's maybe a 5-year gap before the first report of ketamine having some sort of rapid onset antidepressant effect. I guess since then, the challenge has been how do you harness this? What sort of clinical role does this have? And I guess the clinical trials we've been involved in tried to tap into that. So some initial trials we did were using ketamine for relapse prevention, say following ECT for severe depression. And then more recently, the carbon depth trials you mentioned, we did a pilot trial with a definitive trial underway at the moment, where we're using ketamine as an adjunctive therapy, so adding it into regular treatment to people who are admitted to hospital with a depressive episode to see if we can get them better more quickly and perhaps more well even. And part of that, we're following people up for 6 months as well. And this is a cost effectiveness component to it also. So we're very much trying to look at, it's a real world trial, trying to look at is there a potential role for ketamine, on a limited basis over a few weeks of inpatient care, and then see what happens in the longer term.
Great. And Dr. Cantor, your experience with ketamine?
Well, first of all, thank you, Phil, for the nice introduction and also for inviting me to this webinar. Yeah, so as an electrophysiologist, I first came across with the exciting part of ketamine when it has been shown that it produces a massive increase in high-frequency EEG oscillations, mainly in the gamma frequency band. Of course, just like many of us, I've been using ketamine routinely for rodent surgeries for anesthesia, but that discovery that a much lower dose, the so-called subanesthetic dose, produces quite different effects in animals was kind of surprising. But we still didn't think much about using ketamine as an antidepressant because it was linked to schizophrenia, and there were many studies demonstrating that not just ketamine, but pretty much all NMDA receptor antagonists induce symptoms of schizophrenia in healthy volunteers and also in schizophrenic patients. So why would you like to try such a compound in depressed patients? But then it was a big news when it has been shown that it actually acts as a rapid antidepressant. And then we jumped on the topic and we tested ketamine in a rodent model of treatment-resistant depression. So we ran a few studies back in the days, and the results were quite convincing, quite interesting.
Okay, that's great.
My first experience with ketamine.
Yeah, so I guess we're kind of at this phase now, this renaissance in psychedelic research, for want of a better phrase. But kind of what I wanted to address was where do you think that ketamine may have kind of, forged the path that led to this kind of renaissance? So whether this could be in terms of preclinical development or in terms of the results that we're seeing, or kind of the methods of how to obtain the results, or even maybe around from issues around legality or social and political stigma of using compounds like these for treatment, and kind of, yeah, so where do you think ketamine may have led the way with that? Maybe Preston McLaughlin, if you'd like to take that one first.
Yeah, okay. Well, I think ketamine is quite different, I suppose, to the psychedelics in terms of mechanism of action and type of drug it is. So ketamine is a legal drug. Ketamine is an anesthetic, as I'm sure many people know, used in routine clinical practice since the 1970s. And it was called like a dissociative anesthetic because the observation was people just seemed to be disconnected from their environment, when they were being anesthetized with this drug. And that kind of effect then has been used as a kind of club drug, party drug purpose. Whereas psychedelic drugs, work on serotonin agonism and seem to have a more kind of mind-expanding, hallucinogenic kind of drive to them, and also have a long cultural history all around the world, with South America as part of the world as well, with magic mushrooms, etc. So they've been around for a long time, but they're not legal, as opposed to ketamine being legal. And ketamine, so S-ketamine has got a license from the FDA in the United States. It's been approved in Europe in certain quarters. It's still under review by NICE in the UK. And that's given as a nasal spray as opposed to injection. So, and as you know, culturally, there's a lot of concern around drugs of abuse But really, the big problematic drugs in medicine are tobacco and alcohol, not these drugs particularly. But nonetheless, I'm not, a certain amount of caution is warranted. So I think a certain kind of cultural baggage comes with the psychedelic drugs that's not there with the ketamine drugs, although ketamine is a drug of abuse, commonly used actually. So I think it's perhaps better to separate them out a bit. I mean, I think you look at the meetings tend to be quite different. The audiences go to the meetings for ketamine or go to psychedelic drugs tend to be rather different from an anthropological point of view. Kind of interesting. But so I don't know if ketamine has paved the way. I think the whole idea of re-looking at psychedelic drugs, there's been a sort of renaissance of interest in this in the last decade or so, driven by a couple of things. One is that, back in the 60s, around the time LSD and synthetic hallucinogenic drugs, psychedelic drugs were manufactured, there was an interest in using these for therapeutic purposes, but that got clamped down by the law. So there was really not much done for several decades. But one of the problems we have in treating people with depression is that the drugs we have available, the treatments we use have been around, really haven't changed radically since the 1950s. So when amitriptyline came in and phenothiazines and MAOIs, there hasn't been a huge amount of progress in psychopharmacology for depression since then. So ketamine brought in really something quite different, especially the fact that it was this quick-acting drug as opposed to waiting some long time. If you think about it, prior to that, the treatment for depression that continues to be the most powerful antidepressant has been around for over 80 years, and that's ECT. Very, very effective treatment for depression. So we do need something new in the sort of psychopharmacology armamentarium for depression. The industry has pulled away from neuroscience of treating depression because of all the dead ends that they were meeting. So I think ketamine has served a useful purpose, and now the psychedelics recently in terms of reviving interest in psychopharmacology of depression.
That's great, thank you. And Dr. Cantor, for your point of view with regards to ketamine, have you seen it kind of as a precursor or leader in any way from your point of view?
Yeah, it's definitely an interesting compound, and I was quite confused about its mechanism of action. So I'm not sure whether there is a clear concept about how ketamine can be so effective as an antidepressant. But in terms of what future I see for this drug, ketamine gonna stay with us for a few more years, that's for sure. But I see a future more for blocking NMD receptors, not necessarily with ketamine, because one aspect that probably we should cover today is the aspect of doses, because as we can see by going through the different dose ranges, we achieve quite radically different effects with the same compound. So high dose anesthesia, going lower in the doses, we induce schizophrenia like symptoms. Going lower, we may see antidepressant effect. And actually there are some studies, as far as I know, that in very low doses, ketamine may have a pro-cognitive effect, at least in rodent studies that has been shown. So this takes us to anatomical specificity, I guess. So with high dose of ketamine, probably most of the NMD receptors in the brain are bombarded with ketamine. And as we go lower in the doses, less and less receptors are occupied by the drug, and the effect becomes more specific. So I see a future for ketamine, or mainly for NMD receptor antagonist, but probably we have to find either a better way of delivering the drug to achieve more specific effects, or or to find a way to maintain a low dose in the brain, but for longer. Because the other thing that came to my mind about ketamine is that it has a relatively short half-life. So if we want to make it therapeutically more effective, probably would be important to try to increase the time of NMDA receptor blockade in the brain.
And Professor Robinson, do you have anything to add in terms of your own personal experience? Do you think that ketamine is, do you see parallels maybe with psychedelics now, or?
Yeah, I mean, so I think probably the most exciting thing from my point of view is it's opened a new avenue from a mechanistic, just to do mechanistic studies. It's given us something new to look at in terms of mood regulation, even down to the very fundamentals of the circuits of the brain that are controlling mood and are influencing depression. It gives us also, I mean, I sort of see it a bit like the SSRIs being the next stage. I think ketamine's a bit like a tricyclic. It's the serendipitous discovery that opens up that new avenue. And certainly, I think it's given, from our perspective, it's given us a chance to look at new approaches in preclinical models to really critique what's gone before, even to the point that I think a lot of the literature that exists for the conventional antidepressants will be reevaluated in light of what we're now learning with ketamine. And I think combined, and I don't want us to forget about what we've studied with these conventional drugs, because I think if we look at those with kind of a different perspective, now we've got the advances we've made with what we know about how ketamine affects the brain, can we sort of bring this all together to really start to advance our understanding of what causes depression? I don't think ketamine is probably the future treatment at all. I think there are enough concerns out there, even down to, I think one of the things that, and I'm not involved clinically, but talking to people, the perspective is that this is a drug of abuse. They have anxieties about being given it. So I think it would be, just from a clinical perspective, I think people will be much more accepting of a drug that is not already known to be a drug of abuse. And I think that's going to be important. We don't want stigma. We want people to, be positive about taking this. I think that actually I'm surprised by some of the similarities that we're seeing between these different drugs that have been shown to have rapid acting antidepressant effects. So mechanistically, there is overlap, and obviously we've heard things sort of this idea of psychoplastogens and seeing where there is overlap between, so drugs that share the same kind of effect on mood. Looking back from that, we're seeing that they have these same neuropsychological effects, so they're able to modulate important aspects of kind of higher emotional processing in the same way. And then as we move back into the kind of more molecular cellular, we can see that they converge on this, this glutamatergic system. There are clearly differences. And I think as we utilize those drugs, I'd like to see, I think we will learn much more by looking at all of them and comparing where there's overlap than perhaps we would by looking at them in isolation. And so I think the psychedelics will add to the story. I don't think these will all work independently. These are all going to add to a story. And with good preclinical models and thinking about dose, I mean, Dr. Cantor has talked about dose. I think that is a big area of concern, is that we can't just assume that any dose of ketamine that does something to the brain is telling us about depression. It might be not relevant. We have to be very careful to use the right doses in our preclinical models, and particularly when we start looking at molecular cellular mechanisms and relating those to behavior and clinical effects. We've got to make sure that we're using relevant doses, occupying relevant receptor populations, and not just getting interesting effects because we've used a high dose of ketamine. So yeah, I think it's a trailblazer, but it's also, so important in terms of reinvigorating enthusiasm for psychopharmacology, and giving us something to start from and move forward from.
And I guess following up on that, again, I know both of you kind of touched on where it might go in the future, but maybe to bring it back to right now. So where do you see, what's ketamine's role now, and where do you see it? Is it just kind of like a tool, or how would you see it be most useful at the moment? And maybe Dr. Cantor, if you'd like to think about that.
Yeah, so there is one aspect here that I would also like to cover when it comes to ketamine, and not just ketamine, but psychedelics. And this is particularly important when we talk about depression. And also Emma mentioned that where are the overlaps in terms of drug effects. And one thing that I would mention here, which is quite similar no matter whether we use ketamine or one of the psychedelics, is suppression of REM sleep. And that's not just after ketamine or psychedelics, but we can see that REM suppression pretty much after all antidepressants. We're still not quite sure what's the link between REM suppression and in the changes in symptoms of depression. There are, of course, many theories and speculations, but this is something that we could see across the history of antidepressants with pretty much all the drugs. What I would emphasize here is that what makes psychedelics special, based on my experience, is that the REM suppression after psychedelics is very selective and very effective. It's not quite that after ketamine, because ketamine has some other effects as well, but after psychedelics, that REM suppression is very selective when it comes to sleep and EEG changes. And then we see the effects of the psychedelics. So this is something that probably will generate a lot more interest in the future.
Professor Robinson, maybe do you see what you see ketamine as now, as a tool, or I'm thinking from you're also coming from a preclinical background, and then we'll go to Professor McLaughlin, obviously from the clinical side of things.
Yeah, I mean, so from a preclinical perspective, I think one of the things that's really interesting is this sustained effect, and it's not something that we're used to as psychopharmacologists. You know, we expect drugs to have effects when they're present, and we expect that to wear off in a dose-dependent fashion. So this is really novel, and I think, you know, we need to think very carefully about what that might mean. And I don't think it's necessarily just, I think it is a really important aspect of what happens in the treatment of patients with these drugs. You give this single dose, it has some very profound effect. And we certainly know it happens neurochemically. You get this very obvious change in the neural plasticity, probably as a result of that. But then that enables something to then remain and be sustained for many, many weeks with the case of the psychedelics, certainly many days with ketamine. And so I think it's also, we've got to think about why that happens. And to me, it's suggesting that there's more than just this biology. This is not just about changing a neurochemical environment. It's how that change in the neurochemical environment then leads to a different psychological, the different side of the psychological side of it. And so it's not that easy to think about as a preclinical scientist. We're not used to doing that kind of stuff, but we're trying to do that now. We're trying to actually say, okay, so how is it that we can change this kind of baseline chemistry? And then we can look at how, for example, simple things like reactivating emotionally relevant cues, what happens then to that information processing. And so that, as a preclinical scientist, it to me is a new aspect even of pharmacology that we need to think about, and we need to explore that at a fundamental level. And then, and ketamine's the perfect drug to do that. We know very well from this huge amount of clinical data that the drug is present for a very short period of time, and then the antidepressant effect remains in these patients for, you know, hours, days, weeks afterwards. And that is where I think we're going to get our really interesting insights. And then looking at how do we capitalize on that? How do we use psychological interventions to make these drugs work even better?
That's great, thanks. And then, so Professor McLaughlin, obviously you still very much actively involved in ketamine research in the clinic. So where do you see it as kind of its biggest strength at the moment?
Well, in this part of the world, like Ireland, the UK, there's really, I mean, ketamine is being used off license for treating depression for a starter. Ketamine is the version that's, available as a proprietary compound, licensed, has a license to treat depression in some parts of the world. So ketamine, by and large, theoretically researched. But having said that, if you look at the United States, you can Google ketamine, you will find hundreds of clinics that are giving ketamine for treating all sorts of stuff, not just depression. And often these are not run by psychiatrists. These are run by emergency department physicians or anesthetists who are giving ketamine infusions. Some are, some aren't using, depression assessment tools and so on. So it is a bit of the Wild West out there with regards to the clinical ketamine field in the United States. This hasn't happened too much to my knowledge yet in this part of the world. So what I say to people who ask about these trials is say, well, we are using it for research purposes only at this point. We don't have a clinical ketamine infusion clinic, it's research clinic. And as I was saying before, it's not really clear to me what a precisely defined clinical role there is for ketamine. I suppose there's a couple of areas of interest. The licensing from the FDA has it for treatment-resistant depression. What exactly that means, I'm not too sure either. A lot of that isn't necessarily depression, it's other things that just don't respond well to depression treatments. And that's to do with patient assessment and selection and so on. So you have to bear in mind as well, from a clinical perspective, the trials to date, there hasn't, most of the trials are pretty small, apart from the ones that are done for intranasal S-ketamine by Janssen, the rest of them are small for ketamine. So collectively, you're talking about hundreds of people, not thousands and thousands and thousands. So the data set we have is rather small. And what we see is maybe the remission rates are of the order of 25 to 30%, which isn't very high, actually. But the advantage is perhaps this rapid onset effect. So one potential clinical role for ketamine, which is of interest, is there are reports and some meta-analyses out now showing that ketamine has this sort of rapid anti-suicidal effect. It diminishes suicidal ideation. And maybe there's a role for that in people showing up to, say, emergency departments who are actively suicidal and giving them some relief from this terribly distressing symptoms. But then again, what you do 24 hours later, when the effect wears off. So it doesn't really address perhaps all of that, but it may have a role in managing actively suicidal people. As I said, in the trials, we've designed trials in such a way as to give ketamine on a kind of limited basis, because obviously there is this concern about repeatedly giving people ketamine and concerns around dependency and so on. Although I think done in a kind of routine clinical environment, I don't think this is a big issue. But we don't have, there's very limited experience there about long-term use of ketamine out there at the kind of levels that's used clinically, this kind of low, sub-anesthetic dose. So what we have tried to do in our trials is say give people, say, either 4 infusions or up to 8 infusions within a certain time frame, and for either relapse prevention purposes or for adjunctive purposes. One of the concerns in the community who are using ketamine for recreational purposes, say using it 2 or 3 times a week, is that this can have an effect upon your bladder and cause a very unpleasant bladder condition where you get damage, erosive cystitis, which can be irreversible and means you have to have your bladder removed eventually. So that's something to be careful of. But I think that's quite an extreme phenomenon that really shouldn't happen in routine clinical practice. So precise role for ketamine in routine clinical practice, I don't think is there yet, in my view. I'm not too sure. I mean, I guess what it's been used for, the license it has for treatment-resistant depression, by that we kind of conventionally mean people who've not responded to 2 or more treatments for depression, antidepressant drugs at an adequate dose for a reasonable amount of time. And this is what it has a license for. But the problem is, we know that from other trials that the more resistant people are, that portends future resistance as well. So maybe ketamine is better off being used as a first-line treatment for depression. I don't know, but that seems unfeasible as well, considering the nature of the drug. And it actually costs a lot of money. I mean, ketamine itself is cheap as chips. S-ketamine is expensive, but the cost around ketamine is actually the monitoring the individual for 1.5 to 2 hours to make sure their blood pressure is okay, their vital signs are okay, they're not getting any severe dissociative symptoms, etc. So that's a cost.
Yeah, and the next thing I was going to move on to, you kind of started off the conversation there was kind of around potential kind of pitfalls of using ketamine. So obviously you mentioned some things there. Obviously there's abuse potential and things like that which kind of come to mind very obviously. But is there anything in terms of that may have already happened, maybe with preclinical development, kind of mistakes, people rushing into thinking this is more than it is, or kind of different aspects, or even looking into the future, are there any pitfalls that we have to be aware of with ketamine research? And maybe Professor Robinson, anything?
Yeah, I mean, there's always pitfalls with animal models, isn't there? And we've got to be careful with how we design our experiments, what models we're using, and particularly how we interpret the data. I think the full swim test that's been used a lot as the readout for this, we have to be very careful because there are locomotor effects of these compounds. There's also quite a clear difference between the kind of efficacy that we see with the NMDA antagonists in the full swim, where they pretty much all look the same. And that's not what's the picture in the clinic. So the picture in the clinic is quite different. So some NMDA, so ketamine and some of the selective NR2B compounds are looking quite promising, but many of the other ones are not showing the sustained, certainly they have some acute dissociative effects, but they don't have the sustained antidepressant effects. I think we've got to be kind of careful about how we use the readouts in animals. And we do generally rely a lot on behavioral readouts. And that's what we invested a lot of time in, was trying to sort of rethink that. And so not relying on, a sucrose preference test or a full swim test, neither of which is really very robust in terms of translational validity. Even things like novelty suppressed feeding, these are the kind of the mainstays of the preclinical literature at the moment. And whilst I think we do have some really elegant biology coming out of it, what we don't know is whether that really is directly related to what's happening with ketamine in the clinical and in the patient population. And so I think we have to be very careful how we move this forward. There's been a huge amount of publications, particularly the signaling pathways, which, yes, they're interesting. There's these downstream signaling pathways that are activated, but if you switch on the brain, your neurons, you're going to get all this downstream activation. But what we've got to make sure is it's selective and it's relevant. So the mTOR story is a really interesting example. So we've seen now that mTOR is beautifully blocking mTOR, and the downstream signaling of ketamine through that pathway works beautifully at blocking the behavioral effects in the animal model. And then the clinical trial shows, if anything, the opposite. So there's no evidence of this mTOR pathway. If anything, these patients showed a potentiation. So, okay, small trial, it's got to be looked at. But I think that really, it does highlight the risk of assuming that every preclinical model, that every preclinical readout that we've seen, all these different downstream signaling pathways are directly relevant to what we're seeing in patients. I suspect it's dose dependent, and I think there's, as I said earlier, I think we've got to be very careful. The doses that are used in animals tend to be 10, 25, 30 mg per kg, and these are big doses by comparison to a kind of 0.5 mg per kg dose. So most of our work is 1 mg per kg, and there's some primate work as well, similar 1 mg per kg, showing nice modulation of emotional behavior. So I think when you get the right readouts and you get the translational readouts, you then also get the doses being in the relevant space. And I think that's what we've got to really focus on, and not allow ourselves to get carried away with exciting biology, which may not be as relevant to what we're seeing in patients.
Yeah, that's great. Dr. Cantor, anything to add in terms of potential pitfalls with ketamine?
Well, at a phenomenological level, there was a lot of discussion about the massive EEG gamma power increase after ketamine treatment, and there were many speculations. How relevant is this? Whether it contributes to the antidepressant effect of the drug or not? I'm not so convinced that it has any role in the antidepressant effect. It could be, but so far, based on the research that we've done a transformation, it seems that it may not have any relevance. It could be just a byproduct. So as Professor Robinson also mentioned, it's very important to choose our endpoints correctly. So when, and also just to reflect on what's the importance of ketamine and for how long it's gonna stay with us. I still believe that gonna stay with us for a few more years, and we're gonna use it as a positive control in many preclinical studies, at least, to compare the effect of new compounds to ketamine and probably psychedelics as well. We may never understand how ketamine worked, but there is plenty of evidence that ketamine does work, and just like psychedelics. So it's possible that we stick to a phenomenological approach for a few more years until we discover the mechanism behind it. That's how I see it.
And Professor McLaughlin, anything to, I know you kind of started off on some of the concerns around ketamine, and as I know you mentioned kind of things that aren't maybe taken more seriously than you see in the clinic, but is there any other kind of pitfalls or problems you can see coming up for ketamine?
Well, I think, I guess from the clinical point of view, we have to think about public perceptions around these treatments as well. So we did a small study a few years ago looking at internet news media sources, like online news generating content about ketamine, and it's gone up a lot in recent years. But really, we still found that although people understood it was an anesthetic and it works on glutamate and all that, they still tend to minimize the possible adverse effects around it, and tended to very much minimize the kind of need for having a sort of controlled distribution and delivery of this drug under medical supervision, I would say. So there's this kind of public perception, I think, of these drugs collectively that you can buy them in the mail on the internet and use them at home anyway, if you really choose to do so, or go out and pick something in your garden and take it. But hard to know. So the sort of unregulated use, I think, is a problem from a medical point of view, and obviously, I'm sure it's a concern to the drug companies as well. That how do you manage this? How do you manage that type of those cultural issues and expectations? There's certainly a need out there and a demand for better treatments for depression, for sure. So I think I'm not too worried about not knowing exactly how ketamine works. It's obviously quite much more complicated than just glutamate blockade. It's lots of downstream things going on. We don't really know how most of the antidepressants work. We don't know how paracetamol works. We don't know how ECT works. We don't know how lots of things work in medicine. But the fact that they do work and they're tolerably safe and the risk-benefit ratio is acceptable, we're happy with that. So yeah, I think there may be a role for these things, but it's pretty early days yet still.
Yeah, I agree. So we're gonna have this phenotypic approach for a few more years at least, and there are a long list of drugs that really work, and we don't know. We have no idea what's the mechanism of action. I used to come up with modafinil as a drug used for maintaining wakefulness, and it's been around for 20 years or even more, and we still have no idea how does it work. So, but there are many examples for that.
I guess that then the last kind of topic I wanted to discuss was in terms of the future. I know you've kind of mentioned this again so far, but is there any kind of avenues in terms of kind of new compounds or drugs being derived from ketamine, or maybe ketamine being used with different disorders, moving away from depression, maybe something like that. Professor Robinson, if you'd like to go first, or anything you've experienced with.
Yeah, I can pick up a couple of those actually. So in terms of the sort of next generation compounds, I think so we've got some early evidence that we can differentiate between a kind of an acute dissociative and the sustained effects. We don't know exactly what's behind that, but I get a hint that there may well be the possibility of bringing these two elements apart, which I think is really exciting. I think if we can get more selectivity, the fact that all these, there's the scopolamine, ketamine, and the psychedelics all shown to have rapid acting antidepressant effects, but they're quite different in the side of the psychedelic versus the dissociative versus the deliriant kind of process. So I wonder if those will step apart. And maybe there's an underlying shared mechanism we can get a handle on. And that gives us this exciting prospect that we could have drugs that are not going to be acutely dissociative and are going to still facilitate some of these longer term, perhaps driving these adaptive changes in relevant circuits. And I think the NR2B compounds are the first lot that are sort of hinting towards that kind of a mechanism. And that'll be interesting to see how those clinical trials pan out. And there's some of the opioid circuits that look like some of the opioid targets may also be interesting in that context. In terms of other areas, I mean, one thing that we've been doing is trying to, now we've got a really good readout, we think of a depression-like phenotype in animals. So something that we think really is much more relevant to saying how depressed an animal actually is, and certainly in the context of these reward circuits. We're seeing this in lots of models. So we see it in age, we see it in chronic pain, we've seen it in chronic anxiety models, as well as our kind of typical range of chronic depression models. And that makes me wonder whether actually these very strong affective component, and I mean, you're not going to treat these disorders necessarily completely, but I wonder if we can treat a big component of suffering, and that's the affective component. So if we can relieve some of that affective consequences of long-term illness, of chronic pain, and I think these drugs may enable us to tap into those, you know, targeting those symptoms, and perhaps being more effective than some of the antidepressants. I think some of the conventional antidepressants are pretty good in some of the anxiety symptoms. They're quite good at kind of bringing emotional state from low to neutral, but I'm not sure how much they flip into the positive. And so certainly in our hands, the SSRIs are not looking like they do that very successfully at all. So I think the fact that, and that maybe that's why they don't work so well in some of these other conditions. But I think in things like chronic pain, certainly I'd like to see what these rapid acting antidepressants do. And also, you know, age-related apathy, some of these, certainly around the reward. So there's some nice data on ketamine's effects on the reward circuits and kind of improving that kind of reward motivation. And that's a big aspect of patient suffering. You're not going to cure the underlying biology necessarily, or the main primary disease, but if it gives us a route to improving people's mood and helping them with that symptom, I think it'd be really exciting. And we should certainly be exploring them in preclinical models.
Great. Dr. Cantor, you mentioned you think that you're going to be sticking with a similar method you have been for the next few years at least. Do you see ketamine being used for different disorders in your experience, or?
Yeah, so as I said, I do believe that there is a future for drugs acting on NMDA receptors, not necessarily ketamine, but drugs with higher anatomical specificity. There are already quite many NMDA receptor subtype selective drugs out there, and there are some studies showing differences in their effect. Probably there is more needed there to be done. I think there is still quite a lot of research needs to be done in this area. And this brings me to another thing that that may have relevance to this type of research, and that's about it became a new neuroscience field over the past 2 decades probably, and that's about stimulating the brain in many different ways. And we heard about magnetic transcranial stimulation, electric stimulation of different brain parts, and they achieved really good results with these kind of approaches in neuropsychiatric disorders where drugs were not available or they were not effective enough. I believe was increasing the anatomical specificity of NMDA receptor antagonist or even agonist, or in general NMDA receptor acting drugs. There is a chance that we may achieve similar results in the future.
Okay, great. And then finally, Professor McLaughlin, over to you. Do you have any kind of ideas of what ketamine might be used for outside of depression?
Yeah, well, over the last several years, there's been several publications of fairly modestly sized trials using ketamine for addiction, so addiction to cocaine, very recently for alcohol, with promising results combined with, often combined with some sort of psychotherapy as well. So there's an interest in, if you think, well, one of the big problems we have in depression is we don't know what it is, for a starter. So that's difficult. We have, but you know, emerging theory over the last 20 years that depression is some sort of disorder of plasticity within the brain. So ketamine would seem to mediate some of its effects, certainly in animal models, through plasticity mechanisms that are quite quick in onset. And one possibility is if you look at like a psychotherapy like cognitive behavioral therapy, CBT, really what CBT does is it tries to get the person who's depressed to change the way they think about themselves. So if you're making somebody change the way they think, you're presumably doing something to the plasticity of their brain, the way they think. So one potential avenue for all of these drugs, ketamine perhaps in particular, is that it creates a window of opportunity, perhaps for a day or 2 days, where there's this plasticity change within the brain, and maybe you can tap into that using psychotherapy, especially something like CBT, to try and maybe optimize or magnify the effect of psychotherapy. So that's really interesting. I think that's a really interesting way that perhaps you could use these drugs on a very kind of limited basis as well. It might be useful. Now that's not anything to do with having a mystical experience or anything else. It's more to do with the basic kind of effects it might have on the brain. So I think that's kind of an interesting way forward, and maybe that might help in a range of disorders like the addiction disorders, maybe PTSD, things like that as well. Just to go back to perhaps point Sandor made, whether ketamine, so ketamine, let's assume ketamine has this neuroplastic effect. We know that ECT, certainly in animal models, has this profound effect of upregulating BDNF, increasing neurogenesis and cell proliferation within the dentate gyrus and hippocampus. But in clinical trials that have added in ketamine, so using ketamine as the anesthetic or giving additional ketamine to ECT, have not improved outcomes with ECT. So there isn't, unfortunately, this additive benefit from adding in ketamine. Now, what trials have done in this area is they've given sort of a bolus of ketamine, like as part of the anesthetic, or they haven't actually given ketamine in the way it's been shown to have an antidepressant effect. And by that I mean is a slow kind of infusion over 40 minutes or so. So that's probably something that needs to be done.
Great. So we'll leave it there. We'll move on to a couple of questions. I think there's one here that leads nicely into that. Somebody asked, what is the significance of psychotherapy in the ketamine treatment for depression, and is there a great difference in its effects with the presence of the psychotherapist, with psychotherapy versus without? Do you see a difference?
With or without a psychotherapist, is it, or
as in, so it's kind of like as an adjunct, you had mentioned, kind of, so ketamine.
Yeah, well, there's a theoretical and there's some small level evidence that outcomes seem to be a bit better. So and there's kind of a rationale for that. So it's certainly worth exploring further. Now I'm talking about CBT with a therapist, like an hour-long session, whatever. The next day you have your infusion, for example, within the 24-hour kind of window. I mean, as you said, the half-life of ketamine is 2.5 hours, but this kind of antidepressant effect goes on for a few days. So there's this presumably some plasticity phenomena lasting longer than just the immediate effect of these downstream cellular and molecular changes that are happening. So if you can tap into that from a psychological treatment point of view, maybe that's helpful.
But this has been always the case as far as I remember. So even with the traditional monoaminergic-based antidepressants, the therapy was most effective when the pharmacological and the psychological treatment was combined. So,
but that's over a long period of time, like over weeks, not just getting the window of opportunity to enhance the. We know certainly that antidepressants or psychological therapy with both treatments is better than either alone.
Yes.
Okay, just another question here. So more on the preclinical side of things, what would you find to be a useful preclinical measure of the dissociative effects of NMDA antagonists? So maybe either Professor Robinson or Dr. Cantor, if you have any that jump to mind.
Yes, a recent study, sorry, a recent study came into my mind that was done at the University of Cambridge by my group, where I spent 6 years. The lab was run by Professor Jenny Morton, and they made EEG recordings in sheep after ketamine treatment. And they found a very special pattern in the EEG. And their conclusion was that that could be probably associated to the dissociative state induced by ketamine. So if anyone is interested in it, then this paper can be found out there.
Professor Robinson, do you have any kind of readouts for the dissociative effects of NMDA antagonists?
Yeah, so what we've been looking at is this kind of modulation of a previously learned memory, and so we've been particularly looking at these affective biases. So there's something happens over that very short term. You can get this quite clear effect after sort of about an hour that's different from what you see at 24 hours. I think simple assays that allow us to look at whether something's psychoactive, as it were. You know, we have got a number of, I think, early screens. They're not specific, but they'll give you a kind of early screen to look for the more kind of dissociative aspects of it, be that locomotor activity or some sort of task engagement. You know, there are ways we can look at that. They won't be specific, but I think they will help us narrow down and screen out perhaps compounds that are going to be very dissociative and therefore perhaps not different enough from ketamine to be of value to carry forward. But I think you do need some specific readouts. I still think we need to invest more in our understanding of and development of rodent models. That's how we're going to be able to get to the bottom of these mechanisms. And I think we've got to accept that what we have is probably not enough. And be that biomarkers, be that EEG, be it, you know, I think there's lots of exciting opportunities, but we need to put some investment into understanding them and looking at lots of different compounds so that we can get those kind of selective signatures out of those and then be able to use those in a sort of early screen.
Yeah, and I would emphasize here the specificity of these markers, because let's say, going back to this gamma example, many things can increase gamma oscillation, and we see increased abnormal gamma oscillation in most of the neuropsychiatric disorders. So it's there. It definitely means something, but it's probably not specific enough. At least our knowledge is not good enough to understand what's going on and why we see these changes. So the specificity is probably very important when we choose an endpoint.
I think it may be that there isn't going to be one readout. I think that may be where we're going to have to accept that you need to look at several readouts, and it's where you get a particular pattern of behavior. And maybe even that's where some of our more sophisticated analysis comes in. Some of the computational methods could be useful in enabling us to pull together multiple domains and then say, right, if you look like this, then you're most likely to have efficacy. I doubt very much at this stage we'll get a single model that's going to tell us everything. And there's no one preclinical readout, I think, that's going to tell you everything. It's going to tell you about what it can tell you about, and then it's through multiple readouts that we'll then be able to get that specificity and get that understanding of and refine down to which compounds we think have got most chance of going forward.
Yeah, it's quite possible because we're dealing with a quite complex problem. It's relatively easy to develop drugs against high blood pressure because we know what needs to be measured, and then it's easy to test whether it works or not. But as Professor McLaughlin mentioned already, what is depression? What needs to be measured here? So what are the reliable endpoints that we should focus on?
A couple of quick ones. Do you think that there is a niche for ketamine to be used as an acutely anti-suicidal treatment to prevent admissions to hospitals? Is that something that practically could happen or would be useful?
Yeah, I'll answer that. Well, I touched on this a bit earlier. So theoretically, yes, but I guess the issue is, you know, what do you do then? So you still have to do all the stuff you would do anyway. But nonetheless, some people are incredibly distressed, at incredible risk, with extreme suicidal ideation for whatever reason. Now, whether ketamine will work only for people with depression and suicidal ideation, I don't know. People present with suicidal ideation in other contexts, not just in context of depression. So whether ketamine has a sort of overarching anti-suicidal ideation effect, I don't know. And precisely how well this can be harnessed, again, is a big clinical issue.
One last very quick one. Does memantine have antidepressant properties?
No.
Not in our hands.
Okay, that's great. Well, I think look, we're coming up on time, so I know there's a few more questions there, but we probably won't get to them all. So might be best to call it a day. I just once more would like to thank the three panelists for taking their time and for joining us. And yeah, really enjoyed the discussion. So I hope everybody else did as well. So thank you very much for your time.
Thank you.
Thank you very much.
Thank you.
Thank you.